Good afternoon, my name is Aoife Kelleher. I'm a paediatric diabetes consultant based in Leeds, and I'm here today to talk to you a little bit about living with diabetes for the children and young people we care for. So our service, we have just over 500 children and young people aged 0 to 19. Actually, we have a few 20-year-olds still in our service as well, all of whom live with diabetes, and they're cared for by our multidisciplinary team. Over 90% have type 1 diabetes, which, as you know, is an autoantibody mediated insulin insufficiency state, meaning that the treatment involves insulin replacement. Over 34,000 children and young people with diabetes live in England and Wales. And there are increasing children and young people living with type 2 diabetes, and we are increasingly making those diagnoses while they are still in childhood. There are a small number of patients with other diabetes types, for example, steroid-induced diabetes or neonatal diabetes, monogenic diabetes, and they really make up a small percentage of our cohort. Now, I'm very aware that these percentages are pretty much the opposite to what you will see in your primary care setting, where the vast majority of people living with diabetes will live with type 2 diabetes. I think it's important to talk about how type 1 diabetes evolves. So by the time we meet children and young people who are symptomatic and are diagnosed with symptoms of type 1 diabetes, they are really at the end of what has been quite a long process in the background. So children, young people and adults who are diagnosed with type 1 diabetes do have a genetic predisposition to reduction in their beta cell mass. And as we know, it's the beta cells in the pancreas which make up about 3% of the mass of the pancreas, which are responsible for insulin production. There are lots of putative environmental triggers and regulators which are assumed to be affected in the development of type 1 diabetes, but ultimately the pathophysiology is that there is a development of a beta cell injury or an insulinitis. And that leads to a reduction in the mass of beta cells which are producing insulin. This can then evolve into a pre-diabetes phase where there is a loss of a first phase insulin response because the production of insulin by the pancreas is actually biphasic. But that does not necessarily lead to symptoms. However, at that point, if we were to check a glucose, perhaps just after eating or perhaps on fasting, we might find that the glucose range is out of range. Only when we get down to about 10% of normal insulin production do children and young people develop the symptoms of diabetes, and that's where the clinical onset is. How long that phase is, how long that pre-diabetes phase is actually very difficult to figure out because we don't know who those children, young people and adults are in their preclinical phase. But there is lots of research going into studies where we can potentially try to identify children and young people at an earlier phase before they become clinically symptomatic with diabetes, because that then lends itself to potentially be trialling some medications which can alter or delay the onset of clinical diabetes. So I've just said to my colleague earlier today, it's very likely that in 5 to 10 years, how we manage type 1 diabetes in its early phase will focus on pre-detection and intervention before clinical onset. So watch this space. I know you will all be aware really of these signs and symptoms of diabetes, but I think it's really important to talk about them because diabetes does not come with a big flag saying, here, this is what I am, this diagnose me. Children often present with polyuria or polydipsia, so weeing a lot or drinking a lot. Beware of the family who come to you complaining that a child has developed a secondary enuresis. So they've been dry at night and they've been potty trained dry at night, and then suddenly they start bedwetting again. Always think, could this be a sign of polyuria and diabetes? Polydipsia can be a tricky one. Children with evolving diabetes don't tend to just drink their specific squash from Morrison's that they like. They will drink anything. The thirst of hyperglycemia is insatiable. It's a really difficult thirst to overcome. Again, just beware in toddlers and young babies who can't actually self-regulate their fluid intake, so they can become dehydrated much more quickly. Weight loss can be very subtle. So weight loss in children, especially to the family who live with them on a day-to-day basis, is not always obvious. And especially for those of you who own teenagers will know when they live in big hoodies and big trousers where you really don't see them on a day-to-day basis. They can actually lose quite a lot of weight before the people who live with them day to day really notice it. So at the time where a family is saying to you their child has lost weight, we really need to consider type 1 diabetes as part of the presentation. And fatigue is really non-specific. But again, children, young people who are really struggling to stay awake at school, or are coming home from school, falling asleep, spending their weekends daytime asleep, not just long lies for our teenagers, but the fatigue can be really debilitating. There's a couple of other symptoms and signs on there that I've added that because I've known children present to primary care complaining of these symptoms, and it's only on questioning that the other symptoms more typical of diabetes have come out. So blurred vision. Children with high glucose levels can experience blurring of the vision, and the pathophysiology behind that is that high glucose levels mean that there are also high glucose levels in the lens of the eye, and a lens that has lots of glucose in it becomes stiffer, and it's harder for that lens to change shape in the eye. So children can present with blurred vision, and we always tell children at diagnosis, if you've experienced blurred vision, give us a few weeks to help support to get your glucose levels back in range, and only then do you think to go and get your glasses prescription reassessed. The sixth step I have in there to think about is when children and young people present with infections or abscesses. So there is a nurse that I work with at the LGI who, as she says herself, is old school, but she was always taught that if somebody presented with an infection or an abscess or a boil, that you should check a glucose in their urine. Obviously now we have the ability to check blood glucose finger prick instead as well. But it's considering whether that could be a presentation of diabetes. I have seen young children present with significant thrush infections with Candida, and that has actually been their first presentation with diabetes. Equally, I've also had somebody relatively recently who was presented with a pilonidal abscess, and they have had to come in and have that drained during their diagnosis with diabetes as well. So just beware those presentations with significant infections, perhaps acne infections as well, skin infections, and just think to ask the other questions, are there other symptoms that may lead you to consider a diagnosis of diabetes? And the reason why these symptoms are important is because our goal is to try and diagnose diabetes as early as possible before children become clinically really unwell. And this statistic really hasn't changed, unfortunately, over the last 15 to 20 years, where about a quarter of children newly diagnosed with diabetes actually admitted to hospital in diabetic ketoacidosis, or DKA. And we all know that DKA is associated with a significant risk of morbidity and mortality. So there is a DUK parent experience video that I have a link for on this slide. So I'd really encourage you to have a little look at this, because it just explains from a parent perspective the signs and symptoms that she was witnessing and her experience of around her child's diagnosis with diabetes. So it's about 2.5 minutes long, worth a good look. So this poster I'm really hoping you're already familiar with. So these posters are available free from Diabetes UK. So I would be really keen that if you look on their website, you can download these posters, you can ask them to send them to you, you don't even have to print them. And they're about the 4 T's: toilet tired, thirsty thinner, with the goal to try and share the symptoms of type 1 diabetes with anybody who comes into your practice and really out to the public. Because the more of the public that understand these symptoms and understand that they could be associated with diabetes, and could just say to a parent, they're drinking a lot, more than I would expect, could it be diabetes? I think you should go and see your GP. That has been known to happen, especially school teachers have done that in recent times, which has been really meant that those children have been diagnosed earlier than they otherwise would have. So anything we can do to try and share that public knowledge around what the symptoms of diabetes, I would really encourage you to support. So this is a Diabetes UK type 1 diabetes pathway that is available through their website. We do actually have our own in Leeds pathway for the diagnosis of children with diabetes. And I would have the link to that in a later slide, which I'd encourage you to have a little look at. So in terms of that goal to prevent diabetic ketoacidosis, our statistics are that 16 to 24% of children and young people are not diagnosed until they present in DKA, and a significant proportion of those have had a contact with primary care in the week prior to presentation. So there's a significant morbidity and mortality risk, as I've already said, and just consider the signs and symptoms. So ketosis, high ketone levels, can cause an ileus, and that can cause significant abdominal pain. And I've seen children present referred into ED with a query diagnosis of appendicitis. So just ask about other symptoms of drinking a lot, weeing a lot, etc. Tachypnea, if somebody's acidotic and they're in DKA, they will have a fast respiratory rate and also quite a distinctive respiratory pattern with a prolonged expiratory phase. Again, I've seen children being picked up as query lower respiratory tract infection, for example, when they present like this. Ketosis tends to cause nausea, vomiting. The most common thing we say to children and young people and families who have a young person in their family who live with diabetes is, if they are vomiting, always check ketones. And that's really important because vomiting illnesses could present very similarly to DKA. At the point where somebody is confused, we're in trouble because their GCS is impacted. So that is an emergency and they need to be seen immediately in hospital. I don't know how many of you can smell pear drops. If you've ever smelt ketones on a toddler's breath, or if you've been working in a hospital and seen somebody in DKA. Less than 50% of us have the enzyme in our tongue, which means that we can smell ketones. Unfortunately, I don't have it, which would be very useful in my line of work. But again, if you have somebody in your practice or anybody you know who can smell ketones, they can actually diagnose DKA from the waiting room, which is very useful. But any pear drop breath, sweet smelling breath, again, just let it make you think. Ask those questions about the other symptoms of type 1 diabetes. I've shared with you today just a letter, which thankfully now is quite old, but it is to highlight the fact that if you suspect diabetes, whether it be in any sort of symptoms whatsoever, if you think this child could have diabetes, the correct path to follow is to follow our protocol. It does not involve doing a fasting glucose or a HbA1c in children and young adults. And that's because we know that trying to wait for a blood test and getting a HbA1c result could significantly delay the diagnosis. And we know that children, by the time they're symptomatic, they can actually become very unwell very quickly in DKA. So therefore, if you suspect a child or young person has diabetes, please have a look at the pathway and please refer them in through PCAL into the CAT unit where we see them on the same day. If you have any questions about that at any point, or if you feel that you're worried about a patient and not sure whether they have diabetes or not, PCAL is your first port of call to the paediatric consultant on the end of the phone. But there is always a diabetes consultant on call as well for paediatrics. You can always get us through switchboard too. So that is a slide just showing you the flow chart for the primary care referral pathway for children and young people, which basically says any signs or symptoms, please do a finger prick glucose. And if there are any concerns, even if that finger prick is normal, please pick up the phone and talk to us. We are very approachable. We would much prefer to have a conversation with you and decide how best we should see that young person. And again, that's a link for you to take you directly to the pathway to keep it on file. So this slide again is a very old slide, but I think it illustrates what we're trying to do in terms of management of type 1 diabetes, and I really wish it was this easy. So children, as I said, who present with type 1 diabetes, they're insulin insufficient. Our goal is to replace that insulin. That means that we have to try and be a pancreas, which is actually a really big job. So insulin is produced in the background all the time, on, off, in very close relationship to the plasma glucose. Really, every few seconds, the delivery of insulin, the production of insulin and secretion of insulin into the blood is delivered to keep the glucose in a very, very tight range. Every time somebody, any of us who don't have diabetes, start to eat, our pancreas will actually be starting to deliver insulin to the blood to match that food, even while food is still in our mouths before it ever gets to the stomach. And so there is a bolus of insulin or a production of insulin, a spike of insulin produced to match the absorption of food and the transfer of carbohydrate in particular into glucose, the absorption of that glucose into blood. So very, very simply, if somebody's pancreas is not producing enough insulin, we have to be that pancreas. We have to give basal insulin, and so a long-acting insulin in the background. And every time somebody eats, they need to understand how much insulin they need to take in advance feeding to match the food they're going to eat, to make sure that that insulin is there and working at the time the food is being absorbed, to keep the glucose between 4 and 7 all the time. It's really hard work. So for children, young people under the age of 18 who are diagnosed with type 1 diabetes, and I say 18 because in Leeds we are very lucky to be allowed to still admit our 16 and 17-year-old to the paediatric bed base if diabetes is the reason for their admission. So if they're newly diagnosed with diabetes, they will go usually to our Ward 40 in the Clarendon wing, where our staff have had some extra training to care for young people with diabetes. And supported by the ward staff, they will undergo a programme of education with our specialised diabetes team, led by our diabetes specialist nurses and dietitians. And that will take a minimum really of 3 to 5 days, and longer if they're unwell at diagnosis. So obviously if they present in DKA, the child, young person and their family really won't be ready for the standard education until that child is clinically better 2 to 3 days later, usually. So it's a fairly prolonged admission, and that's really because there is a huge amount to teach a family around caring for diabetes and knowing what to do. They will come home with lots of new knowledge, lots of supplies, and they have to get back to what the new normal will be, which will be living with diabetes 24/7 forevermore. Our children with diabetes will have a named diabetes nurse before they leave hospital, so they will always have 24-hour access to advice and support. And they will have monthly clinic appointments for 3 months initially, and then ultimately once everything is settled and their regime is standardised, they will then be seen 3 monthly, including an annual review. So we really do see our patients very regularly. Our diabetes nurses, psychologists, play leader, youth workers will all also see patients in between those multidisciplinary clinic appointments. So they will have a lot of contact with members of our team to support them to get used to really living with type 1 diabetes. That letter is just a standard letter that you will receive if any of your patients are diagnosed with diabetes, and it just lists the number of things that need to go onto their repeat prescription. One of the big things we hear from families, one of the big stresses they have with the diagnosis of diabetes, as well as the obvious, is actually the fact that they're going to have to get used to getting all these supplies, these prescribed supplies from pharmacy very regularly. So we try very hard to give an initial supply of everything they need on discharge from hospital, but we are very grateful when this letter goes out while they're still an inpatient, if that can be acted on as soon as possible, because it really supports families to have all the equipment that they need from the get-go at home, remembering that they will also need to supply some of this equipment to school or to any other place, and to childminders, etc., anywhere else that might be caring for that child, ultimately once they've had the education to care for diabetes. So we're really grateful for your support in getting those repeat prescription items up as soon as possible. On here there's just some pictures really of the things that our children will go home with. So they will all go home with a blood glucose meter, which can also check ketones as well as glucose, and they will need the specific glucose and ketone strips for that meter, and that will be detailed in the letter that you get. And they need to stay on repeat prescription always, because no matter how children eventually end up caring for the diabetes, whether they end up on technology or not, they always have to have the ability to check their blood glucose and their blood ketones at any point if indicated. All our children start on multiple daily dose injections, so long acting and short acting, so they will have at least 2 pens with cartridges of insulin, and we tend to use the cartridges in the pens that are refilled rather than using the disposable pens. One, because the pens are really hard to get at the moment, as you all know, with the various shortages, but the flex pens can only give 1 unit aliquots of insulin, which for little people and even teenagers, when we're encouraging real accuracy around their insulin dosing, it's important that they're able to give half unit doses. Their finger pricker there, the FastClicks finger pricker, is probably one of the most important bits of equipment. I would really encourage you to, all of you, if you've never done it, is to check your blood glucose with one of those horrible disposable finger prickers. They absolutely sting like crazy. They're absolutely horrible. I'm not saying that the Accucheck FastClicks pen makes finger pricking painless. It certainly doesn't. It's still a finger prick, but it definitely makes it much more comfortable. And there's lots of reasons for that, but that's the reason that that's on repeat as well. You can see on there the needles. We are very specific about the types of insulin needles that we want our children and young people to have. The smaller the better, 4mm needles. And on the next slide I'll show you just the pentapoint end of that needle and why that makes that needle a more comfortable experience for the child. You'll see a Carbs and Cals book on there, which we support families to have. We also now have moved into the realm of apps. So all of our children, young people and parents will have access to apps to help them to count their carbohydrates. And there's glucagon on there as well, because we do teach all families to be able to use glucagon in the event of significant hypoglycemia. So the role of primary care in supporting children, young people living with diabetes is absolutely crucial, and we very much appreciate everything you do. The practical support is fundamental in making sure that the repeat prescriptions are accurate and that things aren't removed unless it is checked with the family and with maybe even with us as a diabetes team that they are no longer needed. I always ask, do people understand how many times we ask children and young people to check their glucose in a day? And back when we didn't have access to sensor technology, we would ask people to do between 8 and 10 finger pricks a day. That's a lot, and they hurt. Now that we've access to sensors, thankfully, they don't need to do as many glucose checks in a day, but they always need to be able to do so. And just consider during a period of illness where we're asking people to check their ketones much more regularly, they might need to check ketones every 2 to 4 hours. That box of ketone strips, the purple strips that they need to check for ketones, there's just 10 in a box. So if families haven't used them for ages and then come in asking for lots or have used them all up, that may well be why. Now that we have access to sensor technology, children and young people do not have to check their glucose quite so much, and the more recent sensors with the accuracy that they have means that hopefully children and young people don't have to check their fingers too frequently, but please always just keep their strips on repeat so that they can do so if needed. How many diabetes-related decisions are made per day by a family? Because I think this is really instrumental with understanding what we're expecting of children, young people and their families who live with diabetes. So during lockdown in America, a young woman living with diabetes decided as a little experiment to put a mark on the back of her hand every time in a waking day she had to think about or make a diabetes related decision. And it was 270 times in that day. And that's because diabetes isn't just at meal times. Diabetes is every time, when you wake up, when you think, what am I going to do today? Am I going to get up immediately? Am I going to actually lie in bed all morning? Am I going to have all my breakfast now? Am I going to have it all up front? Or am I going to actually potentially have a sneaky snack in another hour, which means I'll need more insulin? Am I going to walk to school or am I going to be driven there? How stressful are my first few classes going to be? Am I going to be doing PE? Am I going to be actually sitting down and not doing anything in a very relatively calm class? What's the weather like? Is it hot? Is it not? How does that affect my glucose? There's so many things other than just insulin that affect glucose. And that leads to lots of thinking and lots of decisions made around diabetes in just a typical day. And you can imagine what that is translated to if you're a parent caring for what you have to admit are rather unpredictable toddlers, for example. So having a little understanding and bringing that into your consultations, if you are supporting or consulting with the parent, for example, of a family member who lives with diabetes, just having a little understanding of what their life may be like in terms of stress and how much extra they have to think about than a family who don't live with diabetes is really, really useful. That's the slide I promised I'd show you just about the Pentapoint needle and how the importance of that in terms of comfort. So I know there is a big push on trying to reduce costs, which we're absolutely on board with, but the reason we ask these Pentapoint needles to be on prescription is because they are the most comfortable. And if you're going to need to have an injection every time you eat, every time your glucose is out of range, and twice a day for your long-acting insulin as well, anything up to 6 to 8 injections a day, you want it to be the most comfortable needle you're going to have to use, especially if you're actually having to administer those injections to your child, which I think goes against every instinct we have as parents to hurt our children. The role of primary care in supporting children and young people is absolutely fundamental. We recognise that your support is there for the whole family. Parents may not be able to return to work immediately. In fact, a lot of parents, especially mothers in particular, end up not being able to return to their career, depending on what they did before diagnosis. Our goal as a team is actually to support families to try and get back to their new normal, but just recognising that parents especially may need significant support with adjustments for work, etc. in those first few months as they get used to this new normal. We are lucky in our team to have 2 psychologists who work with us, who are very experienced in supporting children, young people and their families in coming to terms with living with diabetes. And I would really encourage you to encourage families that you meet to engage with those psychologists within our service, because that really is their bread and butter and what they do. Longer term, we do know that there are increased rates of psychological distress for children and young adults living with diabetes. We know the family breakdown rates are higher. We know that there's a quadruple increased risk of developing an eating disorder if you live with diabetes. And I guess, is it any wonder when there is so much focus on food in terms of the management of diabetes? So we do have a much lower threshold for referring to our colleagues in the eating disorder service if we have any concerns about disordered eating or thoughts around eating and weight when there is a diagnosis of diabetes. I think we've seen very clearly in the general population increase in the rates of anxiety and depression, and that's been absolutely mimicked in our cohort of children and people living with diabetes during the last few years in particular in this post-COVID time. In terms of annual care, we recommend flu vaccination annually for all children and young people living with diabetes. So it may well be that most of those children and young people will be captured in the general flu vaccination programme already, but there's always a few who miss it. So just encouraging families to take up the flu vaccination. I would encourage family members also to take it up. We also recommend the pneumococcal vaccination for people diagnosed with diabetes treated with any medication over the age of 2 years. So that is included in their initial letter that goes to you when somebody is newly diagnosed. So again, we're very grateful for your support with encouraging families to take that up. Technology, I did say we can't, things have changed hugely in diabetes care over the last few years, and tech has been a huge part of that. Libre 2 is now a continuous glucose sensor. So I think the last time I did this talk pre-COVID was actually, we were on Libre 1s and they were intermittent scanned glucose sensors. The Libre 2, which is now available and has been for quite a while on repeat prescription in primary care, is a continuous glucose sensor which sends the glucose to either a handset or much more commonly now to a phone. And there's an app on the phone that the child or young person can see what their glucose is, and their parent can also follow them on an app on their phone. It does not replace the use of finger pricks entirely, as I already mentioned, and the use of these is assessed at every clinic visit. So please be assured that we don't recommend that children are given Libre sensors and then they are not used. They are absolutely a fundamental part of their care, and how they use it and how they use that glucose data to support them in managing their diabetes is assessed at every clinical visit. Hot off the press is that the Libre 2 Plus sensor is now also on the formulary, and that is for use with the Omnipod 5 hybrid closed loop system. So that is an insulin pump which can link to a Libre 2 Plus sensor, turning it into a closed loop, and I'll talk a little bit about more what that means in a second. But that may also be some of you who have got children living with diabetes on your list, you may have had a letter from us in the last few weeks just asking you to add these Libre 2 Plus sensors to their repeat prescriptions. So what is the role of technology now? This is the new norm, hybrid closed loops, pumps and sensors that talk to each other. So the way I think about pump technology is that it is still giving insulin subcutaneously under the skin, just like an insulin injection. But the difference is that in the pumps there is only a fast-acting insulin. The vast majority of the children that we look after have NovaRapid insulin in their insulin pumps. The insulin pumps deliver insulin in the background all the time, mimicking that physiological production of insulin by the pancreas. Every time a child then eats, they can enter their carbohydrates that they're going to eat into their handset or into their pump. That does the calculation for them in terms of the carbohydrate ratio. It also adds in a correction for whatever the glucose is, because the glucose from the sensor is linked to the pump. And that allows the pump to deliver insulin through the cannula, through the skin, to keep that glucose in range with the mealtime. The pump and sensor that talk to each other in the hybrid closed loop are also working hard in between boluses of insulin delivered by the patient or the young person. And that means that when the glucose sensor detects that the glucose is going to go low, the pump can actually stop delivering insulin for a period of time to try and prevent hypoglycemia. When the sensor is detecting the glucose is about to rise or is rising, it will tell the pump to deliver more insulin to try and turn the glucose trend arrow down back into the target range. So it is very, very clever, and you can see the young man there Brushing his teeth, has got an Omnipod, so that's the Omnipod 5 pod, which contains the insulin. And he also wearing a Dexcom G6 sensor in that instance. There is also then the Libre 2 sensor, which can work with that system. So there are 4 different hybrid closed loop models that we use in pediatrics that are currently available, using a combination of the pump and different types of sensor. And we choose with the family and young person which system is best for them based on their age, based on their own preferences as well. The pod pump that you can see in that picture is the only one that's wireless. The other pumps that you can see on that screen, the Medtronic on the left and the Tandem on the right, both are wired pumps where there is a cannula with a tubing attached to the pump, and most little kids carry those pumps in a little bum bag on their waist. But that is what is now our baseline goal is that all children and young people have access to this technology. And the new NICE guidance that came out towards the end of 2023 has advocated that all patients, children and adults living with type 1 diabetes and certain other types of diabetes should have access to hybrid closed loop technology. We're very lucky in paediatrics, especially in Leeds, that we have access to that for all of our children and young people now. For those of you who care for adults living with type 1 diabetes, NICE has said that there's a 5-year window in order to get everybody onto the hybrid closed loop technology. So hopefully you will find over the next couple of years, those of you who look after those adults living with type 1 diabetes who don't already have a pump from childhood, because if they go into the adult service already on a pump, they continue on it. But if they are new to pump technology, they should have access to it within, hopefully, sooner than the 5-year NICE recommendation. So on their repeat prescriptions, you will see some extra things if they are on pump therapy in particular. And I've get lots of queries about these from GPs really to say, what are they for and why are they useful? So this tech means it needs to be worn on the skin. The sensors are worn for anything between 10 and 15 days on the skin before they need to be changed. Cannulas for the pump or the pod itself must be changed every 3 days for the majority. There's one pump system that has a cannula can be used for a little bit longer. But that means something that breaks the skin every 3 to 5 days and is adhered to the skin with this adhesive. And children, young people and adults can have very sensitive skin. So Cavalon is a barrier, which I'm sure you'll be aware of for use in lots of other settings as well. But we recommend the use of that on the skin as a barrier sometimes if there is a problem with either sensor or cannula adhesion, or if there is a reaction of the skin to those sensors or to the adhesive. So that can really help with a barrier. So that's absolutely crucial. If you're going to make the skin more sticky, if you're going to make the pump or the sensor adhere more well to the skin, then actually you need something to help dissolve that adhesive before ripping it off. I still have a number of patients who are hardy and just rip off a layer of their skin every time they take off their sensor or their pump, but we really encourage them not to. And Lift Plus, it comes in a wipe form and in a spray form. It's probably better in the wipe form, to be fair. And we really encourage good skincare involves using that to help nicely peel adhesive off the skin. And you may wonder why I'm making such a big deal of this, but this is actually fundamental, because if children, young people have really bad skin reactions or get repeated skin infections because their skin barrier has been compromised, then that means they can't use the technology, and that technology is what will really help keep their glucose levels in range. So they have to revert to pen therapy, which, to be honest, is harder work in many ways. So you will get a letter like this if somebody has been moved onto a pump system. Our goal really is that we're getting young people at diagnosis, we introduce them to the concept of hybrid closed loop therapy very, very early. And in fact, we're trying to put people on it as soon as possible. So even within 3 months of diagnosis now, we're getting patients onto pump therapy, or even sooner if it's clinically needed. They will still always need pens. And that's because tech is tech and it can sometimes fail. We've had pumps drowned in the swimming pool when kids have arrived on holiday and jumped in the pool forgetting to take their pump off before they jump in. We've had handsets that have been smashed. I've had siblings who have taken the pump and stood in it. You know, tech can fail for lots of reasons. And in that case, the families and children and young people always need to be able to revert back to pen therapy to be able to manage their diabetes. So when we ask for Levemir cartridges and NovaRapid cartridges to use in pens to be kept on repeat prescription, this is why. Families should not be getting them every month on repeat prescription, but they absolutely need to be kept in repeat prescription for use in the event of pump failure. And we still have a regular cohort of families who ring up saying the pump is broken, We ring up the company and they have agreed to send a new one out, but it won't be out for the next 24, 48 hours or even longer, because it's always a bank holiday weekend when this happens. And they have to be back on pens, and then they say, oh, I didn't get it on repeat prescription, or I've let it run out of date, and that always causes a bit of a havoc. So we really appreciate being able to keep those things on repeat. I'm just bringing up annual review because it's always something that comes up regularly, and I suppose it's to reassure you when in paediatric practice, so anybody under the age of 19 who's still in our Children and Young People service, they will have an annual review annually, the clue is in the name, but that will include their blood tests for thyroid function tests, TPO antibodies, thyroid peroxidase antibodies, celiac screen and Usinase, lipid profile if they're over 12, and we also do a urine albumin creatinine ratio if they're over 12. So we sometimes get families who've been told they have to come to the GP for their annual review. And I've even had a case where they've been told they won't be able to get the repeat prescription until they come. And I completely understand why. It'll come up on your screens that these families and children and young people need an annual review. But I guess please be assured that they will have that already with us, and just to save you another appointment, you shouldn't need to redo it. The details of the results are all in their annual review clinic letter, which will come, as a copy of which will come to you. Okay. We do look at their repeat prescription items at that appointment as well, and sometimes you will get letters from our diabetes nurses just to update if there's anything needs changing on there. But hopefully that will help free up some of your time for certainly the children in the paediatric service. I know that that's different when our young people go into the adult service, and that they will need to have their annual review in primary care. So the next couple of slides are just on excess weight. And the reason this is part of our diabetes series of slides really is because we are seeing more and more children and young people who have excess weight, living with excess weight. And we know that excess weight is one of the factors that may be associated with the development of type 2 diabetes. At the moment in Leeds, we have just over 30 children and young people who live with type 2 diabetes in our service, and some of whom were diagnosed at I think the youngest we've had is the age of 10. Weight and discussions about weight and lifestyle can be really difficult, especially if somebody comes to you with something completely different. But we know that statistically about 25% of children are overweight by the time they get to reception, so we're talking 4 and 5 year olds, and that's up to 1 in 3 children by the time they reach year 6. They are more likely to be overweight adults, and all the comorbidities that come with that. Specifically, we know that excess weight has a significant link with deprivation. And we certainly see that in our clinic, where a significant number of our families live in situations where money is really, really tight. And we try to make every contact count. So I'm just encouraging you, if you're seeing children and young people for other reasons, just be aware of weight and think about how you can sensitively potentially bring up the topic of weight, because actually if it's brought up in a sensitive manner, you will find that generally parents are open to having some advice about what they can do to support their child to be healthier. The Henry programme continues to run for children aged under 5 and for between 5 and 12 years, so 2 different programmes all run under the Henry heading, and that's through the children's centres. And there is an adapted Henry programme for children and young people with learning difficulties as well, because again we tend to see a higher proportion of children living with additional needs who have excess weight. And the Henry programme is great in that there is a whole family focus, because it's very unlikely that there's only one individual within a family who lives with excess weight. We do have an excess weight clinic currently commissioned, which we're very grateful for, which Dr. Young, one of my diabetes colleagues, supports our endocrine consultants with. And we do see lots of young people who are living with significant excess weight in that clinic, and support them with good results. And that really brings me on to type 2 diabetes. Some people say to me, have I got the bad type of diabetes when they're diagnosed with type 1 diabetes? And I think there is a misconception that type 1 diabetes is worse than type 2 diabetes in some way. But I would say that if you're diagnosed with type 2 diabetes as a child, that is a very severe progressive form of diabetes, and the development of complications is absolutely massive. You're much more likely to have complications in your 20s if you've had type 2 diabetes for 10 years than if you've had type 1 diabetes for 10 years. We know that children who are diagnosed with type 2 diabetes have a rapid progression of both micro and macrovascular complications at a relatively young age, and that their response to treatment is poorer than the equivalent diagnosis in older people. So please consider whether somebody could have possibly have type 2 diabetes in young people. Generally they're post-pubertal, especially if there is a significant family history or if they come from an at-risk ethnic group. And again, it's not just those who live with excess weight. There is a significant genetic component to type 2 diabetes. So I can't tell you which is worse. I think in a way it's a pity that they don't have different names. But the management of type 2 diabetes requires equivalent input from a multidisciplinary specialist team in childhood as it does if you are diagnosed with type 1 diabetes. So if you think a patient may be developing or is at risk of type 2 diabetes, please ring us. Please discuss with the paediatric diabetes consultant on call. We will often see that patient fairly quickly. We are able to then do some glucose monitoring with them. And the earlier we can intervene, the earlier we can support with lifestyle intervention, then the longer we can delay, hopefully, or even prevent the actual diagnosis of type 2 diabetes. So you'd be glad to know that's coming to the end of my slides. The key points I want you to take away in your general day-to-day work is that I recognise that on your caseload you may only come across a new diagnosis of type 1 diabetes maybe once or twice in your career, but missing it has a significant consequence. So I'm just asking you to think about diabetes if somebody presents to you with some of those vague signs and symptoms, even with a short history, but especially in younger children who are more likely to become more unwell even more quickly. Please do a finger prick glucose check and a urine dip, but don't be tempted to do a fasting glucose or a HbA1c. If you're at the point of thinking this child needs investigations with blood tests, please just send them in and we will make those decisions, because we can monitor and safety net those children, young people, and make sure that we do not miss an opportunity to prevent diagnosis unwell in DKA. Refer on the day to the CAT unit via PCAL, and you can always phone us if there's any concerns whatsoever, and there's a link on there for the primary care referral pathway. So I hope that's been useful. If you have any questions, please contact myself or Dr. Stevenson, my colleague. Our email addresses are on there. We're more than happy to have any contact from you and to answer any queries if needed. We're a really good team. There's over 30 of us in our team, and I'm very lucky to work with them. And you know, our diabetes specialist nurses as well. If you have a specific patient in your caseload, please contact the named nurse for that individual patient if you have any concerns about them whatsoever, because we're very grateful for your support for all of these children and young people living with diabetes. And I think there will be a link to a QR code at the end of these slides as well, so if you've got any feedback on this talk or any suggestions for future presentations, I'd be really keen to hear them. And thank you very much for listening.